So everyone, we have Dr. Rogers today. Dr. Rogers has his bachelor's degree from Indiana University, his medical degree from UMDNJ. He did a residency in pediatrics at the Children's Hospital Los Angeles and a pediatric emergency medicine fellowship at the University of Utah. So we're extremely privileged to have him here today. He's coming from CCMC, where he, treats a lot of young patients in mental health crises and drug overdoses and such. And he's also a professor at UConn. So I'll turn it over to you, Dr. Rogers, and thank you for being here.
Yeah, thanks, Joe. I appreciate the introduction. So, so by trade, I'm a pediatric emergency medicine doc in terms of my clinical obligations, but I'm also the medical director for emergency behavioral health services. And you'll notice I changed my title a little bit for my talk, just because I realized the audience I'm talking to. And so I feel humbled to be talking to a group of mental health care providers. I'm usually talking to pediatricians and medical providers who I'm sure I don't, I believe I'm preaching to the choir here, who don't engage well with mental health care providers. And at times, at least in the past, have been resistant to do so. When I got to Connecticut Children's, I will never forget a grand rounds that was encouraging our pediatricians to get involved with mental and behavioral health. And one of our very senior pediatricians in the community stood up and said, well, I didn't go into pediatrics to be a psychiatrist, so I don't know why we're even having these kind of lectures. Luckily, that person's retired. And luckily for me, about 10 years into my stay here, and I've been here for about 15 years, the institution has completely turned around. And I believe most of my colleagues in the community as well, although lacking the tools and likely the training to do so, I think with the supports here in Connecticut have really embraced mental and behavioral health as part of their practice. So some of which is not by choice, but I know that people are seeking help from their primary care providers when it comes to these issues. And we're going to focus primarily on suicide prevention today, but I wanted to give you a little bit of the background of why is this pediatric emergency medicine doctor talking about suicide and how did he get to this point in time? I think it's always helpful to tell a little story. I have no disclosures. Our objectives today are to illustrate the rising rates of youth and families seeking mental and behavioral health care in pediatric emergency departments. So that's kind of an add-on objective. It may not have been on the initial flyer. I'm also going to try to demonstrate to you, and again, I realize I'm preaching to the choir, the prevalence of suicide amongst youth in the United States and how we can help prevent suicide, and then review the importance of providing universal suicide screening, both in your practice as well as mine, and how we, I think, have demonstrated that it's feasible even in a busy PZD, and then recognize in little pieces here the potential impact of the pandemic on youth mental health and suicidality. So this is a historical chart that we published many years ago, pre-pandemic, demonstrating that across the country, we pulled data from this huge national database looking at ED trends and discharge diagnoses. Each region is color-coded if you're interested, but I don't think we have to get into the details of this. Basically, it shows that in every region of the United States and then overall in the United States, pediatric emergency departments are seeing more and more kids who are leaving the ED with a primary diagnosis that is mental or behavioral health focused. And so, which to me is easily translated into that's why they showed up there for the most part. And then we looked at more recent data from this database. It's called the Pediatric Hospital Information System. We looked at birth to 17 years. We looked at, this is the historical one, sorry, 5 years of data and 44 US children's hospitals. We were able to look at like 13 million visits back then and notice that it's around 150,000 visits that ended with a psychiatric diagnosis. And that's that same chart I just showed you. But when we fast forward and we look at the last 5 years of data, we were able to look at 18 million visits, and instead of 150,000 patients, it was 600,000. We only added 1 year's worth of extra data on there. So even if you knock that down to 500,000 or even in the 400s, it's literally more than double what we've seen in the past. And that's the trend at Connecticut Children's. Our growth has been what I describe as exponential. And so it's definitely an issue for other places in the country. And so we demonstrated once again that we had a significant increase. You can see we had some downward trends for some of us in the Northeast at least, but even the Midwest went up during the pandemic. We had just lower overall ED volumes in general, but certainly felt like we were seeing a lot more acuity during the pandemic and quarantine era, which is hopefully going to stay behind us at this point. But in general, in that 5-year period, there's been statistically significant growth across the country. Our conclusions from looking at this data is that the increase in pediatric ED mental and behavioral health volumes has increased. Like I said, these kids consume vast resources in what are already very busy, limited EDs. And most providers receive limited mental and behavioral health training, so it makes it difficult for us as emergency medicine providers to really care for these kids the way they need it. So research, education, and quality improvement needs to be a priority, not only in our pediatric emergency field, but also in emergency medicine as a whole. So what have we been doing on RED? I know most of you are probably not familiar with RED. We actually see very little patients seeking drug addiction care and withdrawal care. It's been an issue recently with a few patients. And I don't know if it's a product of going to more adult EDs, which I can't track out, or they just are seeking care in the community. Or maybe you guys are just doing such a great job that they never make it to us. But with the growing volumes of mental and behavioral health patients, we built a separate unit that is ligature safe and nearly up to standards of an inpatient psychiatric unit. The rooms were designed to flex. Can you guys see my pointer? So this is an example of a room that is a flex room. So it can flex from medical back to behavioral health. If we close this door and we get rid of these flimsy chairs, then the room is ligature safe. And so the ED, which showed the mentality about 5 years ago, they were in transition. They said, yeah, we'll build this extra unit, but we have to be able to use it for medical because we're still primarily in the business of providing medical care. And so that we built this unit, we hired psychiatrists, advanced practice providers, APRNs and PAs. We hired our own social work team. I think we're up to about 6 or 7 full-time social workers. We have a lot of per diem and part-time folks. We have since that time hired dedicated behavioral health nurses, behavioral health techs, child life staff. We have what we call patient care partners or sitters, and we have our own dedicated security staff that's in the unit 24 hours a day. And in fact, the institution has embraced it so well that we are actually going to convert this back to medical space and build a brand new behavioral health unit, observation unit that will be able even more advanced than the one you're looking at in terms of therapeutic space, open space, and our lengths of stay in the ED for our behavioral health patients when we are in a bed crunch, meaning that actually we have no inpatient beds, but when the state is in a bed crunch, we can have kids with us from 6 hours to 6 days. And in fact, I think our record is over 6 weeks. And so you could imagine being in our emergency department for 6 weeks is not a healthy outcome. We have designed policies, procedures, pathways, workflows, everything you could possibly imagine to help hopefully create better flow through our ED, but it's difficult when you have limited outpatient resources. We're doing research on what we call the Emergency Behavioral Health Assessment Tool, or EBAT. It's a tool that helps us assess each patient individually, but also the entire department. If we can add the scores and come up with an acuity level for the entire unit, we're hoping it will help us guide staffing. And it also provides an objective way to score patients, meaning it's almost like a behavioral health vital sign. which helps us guide their management. So if they're starting to escalate, meaning they had no risk, now they're showing some low risk behaviors, this part down here gives our clinical staff, this part gives our clinical staff some guidance on what to do. This is the actual scoring card. Details are really not important, but my point just being that we're trying our best on a regular basis to be innovative and provide better care. But as they pile in, you can see that red line is kind of our behavioral health unit capacity. It's really a 15-bed unit, but we can squeeze in 19 patients if we need to. And you can see last year, we exceeded our capacity on most months or many months. And so that makes it really challenging to be in the ED. And you can see after COVID hit, we had this slow, steady rise of length of stay. So our patients were getting stuck with us for longer and longer periods of time, peaking out at hundreds of hours. So it's been really challenging. And this year seems to be a little better, but I don't want to jinx anything. So dealing with all this volume and everything else that was going on, as the medical director, I was like, well, what should my priority be? As an ED doc, we like to triage patients and see the ones who need us the most first. And so I wanted to sort of focus in on one aspect of our mental and behavioral health patients. And that aspect, I believe, is suicide. Many of our patients are coming in for it, but most importantly, not only, it's the one diagnosis in a sense, or one thing in mental and behavioral health care that they can die from. And here in the US, we're seeing somewhere between 46 and 48,000 deaths per year. That's about one death every 11 minutes. Suicide deaths have increased by 30% since 2000, despite many efforts in terms of prevention. It's the second leading cause of death, starting at the age of 10 and going through 34, and we'll talk more about that. And it's more than 1.2 million people reportedly attempt suicide every year, and it's probably way more than that. These are whiskers charts. It's a crazy chart that I occasionally get feedback like, hey, don't put that in your talk. Nobody can read that thing. But if I break it down like this, across the top, you can see various age ranges. It starts off with less than 1 over here in the corner. And the number one killer for kids less than 1 are congenital anomalies, meaning they're born with something wrong with them that's not compatible with life. That kind of makes sense. And then going down this column, it's top 10 causes of death. So the CDC puts these charts out every year, and it's very telling because back in 2014, when I had a 10 and a 12-year-old, my son was 10, my daughter was 12, I looked at a change in this chart, which was this. Starting at the age of 10, suicide became the second leading cause of death back then. I couldn't believe that my kids even knew what suicide was at that age, let alone actually think about it or even attempt it, and realize that kids are dying by suicide at a younger and younger age. Fast forward to the most recent CDC whiskers charts in 2020, we do see a little bit of a change. Suicide dropped to the third leading cause, but sadly that's because homicides exceeded them in the age range of 15 to 24. But still, basically, the second or third leading cause in our adolescents and young adults. And I'm sure you guys have dealt with, unfortunately, many a suicide or deaths that could be suicide related. Here's the scary part about the 2020 data. All of a sudden, you see this little green box pop up as the 10th leading cause of death in kids age 5 to 9. I had a hard time believing a 10 and 12-year-old, let alone a 5 to 9-year-olds would actually be dying by suicide. While the numbers are low, it's still extremely concerning and something that I think is telling us we need to do more about it. Rule number 1, turn your phone off when you're presenting. I don't know how familiar you guys are with, and this is the hard part about not doing these talks in person, because usually I can see heads nodding, but I can't see much. I don't know how familiar you are with the youth risk behavior surveillance system. It's a CDC funded every other year anonymous survey of adolescents, meaning high school age kids, about risky behaviors relevant to you guys, drug and alcohol use, unprotected sex. And one of my focuses on it is there are questions in there. There is questions in there about suicide. Again, this is considered highly reliable. It's anonymous. It's massive data. And the results are always really interesting and telling because it's kind of a way of looking into the cumulative minds of our high school age kids. One of the questions asked about seriously considering attempting suicide in the past year. And if at least in your mind, you can sort of take a guess, how many kids said they seriously considered killing themselves in the past year? And so this is a graphic, outcome measure or outcome report. So nationally, it's about 19%. Here in Connecticut, it ranges anywhere from 17 to 19%. That's not good. That means 1 out of 5 kids at some point in the past year has thought about killing themselves. And so we've got to be missing something along these lines. How many said they actually attempted it? And this one's kind of the one that really gets me. Again, you can see high variability across the country, but it's about 9%. Connecticut's usually about 8. It ranges anywhere from 6 all the way up to 20% in some states. And so, that means for us, somewhere around 1 out of 10 kids have actually attempted to kill themselves in the past year. And if you do the numbers, that's way more than the 1.5 million people that they report on a national level. Like I said, Connecticut just barely trails behind the overall average in the United States. We're a slightly safer state for lots of things. Our rates are about 1 suicide every day in Connecticut. It's the second leading cause of death in kids 10 to 34 in Connecticut as well. Interesting fact that more than 3 times as many people die by suicide than alcohol-related motor vehicle crashes. And I always like to point out that, again, with the show of hands, most of us have seen a do not drink and drive ad campaign, probably in the past week, maybe even the past couple of days on billboards or on the radio or on TV. And I sort of challenge people to answer the question, have you seen anything about suicide and mental health? I actually have seen a couple billboards over the past couple of years, but not very many. I certainly don't hear a lot about it on the radio or see much of it on TV unless it's some very depressing report. This is older data, but it's from our own Connecticut Department of Public Health, just confirming that in our adolescent population, suicide is the second leading cause of death. And this is the means of suicide in the state of Connecticut versus the United States. I think the interesting thing here is you see that firearms are the #1 cause of suicide or means of suicide, followed by suffocation or hangings. Connecticut, it's interesting, suffocations is #1, and firearms are #2. So it's really interesting in terms of the fact that we have very safe and restrictive firearm laws compared to some other states, and they tend to go hand in hand. If your state, for example, like Colorado or New Mexico, have very little firearm restrictions, then there are very high suicide death rates. And it's clearly #1 in those states. So they kind of go hand in hand. Just an interesting fact. So I think that the thing that I don't have to tell you guys, but I have to tell a typical audience is suicide is preventable. There are folks out there who still feel, well, what are we going to do? If they really want to die by suicide, they're going to do it. But that's not the case. And I like to point out to my audience that if you or anyone you know is struggling with suicidal thoughts, the crisis line is here. It's 988. It's easy. It's 24 hours a day, and they can connect people to resources that they need. So how can we help our patients right now? Again, this is just a glimpse into what I try to convince my colleagues to do, which is 3 basic things, which is we just need to identify patients at risk for suicide. We need to connect them to the right resources like you guys. And then we need to provide at least some preventive advice or put some prevention measures in place for those that are unsafe. So years ago, the Joint Commission came out with it. It was, I believe, in 2018, came out with Patient Safety Goal 150101. And if you guys aren't familiar, the Joint Commission is our accrediting body that allows us to get paid by Medicaid. And so without that accreditation, we can't qualify for that. And that's about 60% of our business or more. And so we follow their patient safety goals and we follow their requirements. And we are, in a sense, inspected by them on a regular basis to make sure that we are complying with their safety standards. So we leverage this and a not so coincidental publication at the same time that outlined how an institution like mine can screen patients for suicide, meaning we're not a dedicated mental or behavioral health center. We're not, we don't have inpatient services, but we should still be making sure that our patients are safe and that if they are at risk for suicide, that we are providing them or connecting them to the appropriate care. There is an inpatient pathway for this. There's an outpatient, meaning a clinic pathway, and this one happens to be the emergency department pathway. We took this pathway, and I know it's got a lot of detail that you guys probably aren't that interested in, but we took it, we trained our staff. I don't know if you guys are familiar with QPR training, but we provided QPR training for all of our ED staff, and then we made this. This is our workflow, and it's pretty simple. Oops, let's go back. Patient comes in if they're 10 or older. We screen them with the ASQ screener, and I'll show you that in a second. If they're positive, they actually get, meaning if they're non-acute positive, they get a secondary screen and a risk assessment. If they're high risk, they get seen by social work. If they're moderate risk, there's some clinical contemplation that occurs, meaning that they talk with the family, the patient, and assess whether they have adequate resources in the community. And if they're low risk, most, if not all of those, go home with appropriate resources. So the ASQ is a validated screener that came out of the NIMH with a toolkit that looks kind of like this. I don't know if you guys use a screener or not. We can talk about that, I guess, towards the end when we get to questions, but feel free to raise your hand or interrupt by unmuting at any point in time if you have questions. This is a 4-question, 40-second screen. That's how I got past my staff saying it's going to take too much time. It's going to take too much time. I was like, well, I think we have 40 seconds to ask somebody a couple of questions, especially when our average length of stay is about 2 hours. So they get asked up front by nursing staff after the parents have been asked to step out. Most parents don't have a problem with that, believe it or not. And our nurses have a really good compliance rate when we first started this, and we followed our data. So our goal in the first 2 years, and this is our first 2 years of screening, was 97%. We actually achieved it at least in one month. And I'm sorry, the data points are kind of small, but I think the overall concept is that we screened well over 30,000 patients in the first 2 years, 91% compliance rate by our nursing staff, which is outstanding for any quality improvement project. And so I think the training really helped. They understood why they were doing it and why it was so important, and also helped that leadership had full buy-in. And if you missed more than 1 or 2 screens in a week, you got called down to what I call the principal's office or the nurse manager. And there was discussion as to why you might be missing screens. And so again, I think our compliance rate was great. They're actually 98% compliant with mental health patients, which is really outstanding as well, and really have maintained that. So when patients are seen for a primary mental health issue, almost 100% of them get screened and risk assessed. And this is our results of actually our 3 years. We hit 3 years in August of data. And I know, again, the data points are small, but you can see the trends over time, and I'll try to point a few things out. We've done over 46,000 screens of kids 10 and older. We have about an 18% positive rate. That's 8,600 kids who have screened positive. Within that 8,600 kids, 5,600 or 12% presented with a mental health chief complaint. And I think the real win here is the medical patients. So that's the part that's not necessarily actually required by the Joint Commission. They don't require a universal screening. They require screening of kids with mental and behavioral health problems, which I don't have to tell you doesn't really make sense, because the mere fact that they're presenting with a mental health problem puts them at least slightly increased, if not significantly increased risk for suicide. So finding the kids who have not yet been identified, meaning medical chief complaints like, I have a sprained ankle, oh, how'd you sprain your ankle? Oh, I kind of fell out of a window. And we literally had that complaint. We had an adolescent male who had attempted suicide and it didn't work. And so he said he fell out of a window when he actually jumped out of a window. I don't know how he didn't hurt himself more. But when we screened him, he came back positive, and he was connected to resources, and hopefully he's doing better. But we've had about 3,000 kids who come in with medical complaints, or 6% of those positives. And so it's really telling at times, and really motivating for our staff. For example, in the first 6 months of screening, we had an 11-year-old female who presented, and if you think about an 11-year-old female, is like a little kid. That's like a fifth grader, and so she presented with a medical complaint. She happened to screen positive on the ASQ, and our advanced practice provider went in, screened her. She was positive on the Columbia. She was lower moderate risk, and they called the mom back in and said, okay, let's talk. And when they told the mom appeared like devastated, and looked at the young girl and said, well, what happened? Like, what, I thought we were best friends. And the little girl said, yeah, mommy, we're best friends. And she said, well, I thought as best friends we talked about everything. And she said, we do. And then the mom said, well, why didn't you tell me that you were having these thoughts? And she said, you never asked. So stories like that are really compelling for our staff, and I think have really contributed to our high compliance rates. And this answers a question that many of my colleagues had. Some of them had 10-year-olds at the time and were like, my kids are too young. I would never ask them those questions. I don't want to plant the seeds of suicide, and et cetera, et cetera. And so we've really dispelled those myths, and these numbers kind of tell the story. In the first year of screening, we had 135 10-year-olds screen positive for suicide risk, 60 of which reported that they actually had attempted suicide in the past year. So that's pretty scary. That's definitely eye-opening. We probably should be screening younger. I mentioned earlier, we do the Columbia Brief Safety Assessment for any positive ASQ. This is the Columbia Brief. You guys are probably, I would guess, might be more familiar with the Complete Columbia. And I'm not sure if you guys use that, but our provider staff does that in response to a positive ASQ, because we don't want to what we call over triage. We don't want kids who said, which we see occasionally, will say, oh God, yeah, I just want to die. My stomach hurts so bad. And literally that was like an appendicitis kid who screened positive, but was completely negative on the Columbia after his pain had been managed. And our compliance rate by our providers is outstanding, an average of 97%. And this is the risk assessments that come out of that. And this is a part about the pandemic, or I'm not sure what, but as you can see, our low risk patients, this is the results of the first 2 years of screening. We have seen an increased trend of moderate risk kids. So when we first started, it was great because I got to look at my colleagues and see, as I told you, most of these kids are going to be low risk, they're easy to send home. Very few are going to require clinical decision-making, because the high-risk kids get seen by our social work team or our psychosocial team because they're high risk, many of which go inpatient. Otherwise, they get connected and to services or wraparound services before they go home. But for some reason, that trend has changed. And I don't know if I can say that it was the pandemic or is the pandemic. I know we did see this. If you kind of just squint your eyes a little bit, you can see this sort of ever growing increase in that moderate range, and even our high risk range has expanded a bit. And I don't know if it started back here, if it was going back to school right after quarantine and that started it, but certainly something has changed. And it's not us, and it's something that our patient population is starting to struggle with in terms of more moderate risk kids. And it's really interesting trends. Actually, you know what? And I forgot to talk about this. I just wanted to point out that the pandemic and quarantine was right about here. We did have a blip in ASQ screens as high as 21%. But again, somewhere in the following fall, we became very concerned about these huge spikes and positive ASQ screens in our patient population. And are still concerned that that was the result of the quarantining here or the returning to school right after quarantining here. We always have a dip in the summers. Life is good, I guess, during the summertime, but we are seeing another increase in trend, but not quite to the height we did in that school year after the pandemic. Sorry about that, I meant to mention earlier. Back to those 3 points that I try to get my pediatric colleagues to follow. We do connect patients to services, and I encourage them to use mobile crisis, which will be going 24 hours in the new year. And we're hoping sooner rather than later because it's a great service. I'm sure you guys are all aware it's sort of mobile psychiatric care. It's social workers who are able to go out to the house, meet the patient at McDonald's, meet them in school, and they're having a great impact on the ED. So we really support their services and actually utilize them at times in our ED for low-risk patients. We also encourage our colleagues to use Access Mental Health. It's basically an on-call psychiatrist. And I imagine you guys don't need that, but it's really helpful. And to me, takes away the excuse of, well, I'm not a psychiatrist. How am I supposed to manage this kid's med changes? Well, you can call this person and they can talk you through it. So I really believe our pediatric colleagues in the community or even family medicine colleagues can follow these 3 basic steps. And then finally, we suggest that they use lethal means restriction counseling for any patient that is at risk of suicide. And I'm not going to get into it except to say, my colleagues in the emergency medicine world actually proves that lethal means restriction counseling worked in a study. And I just want to point out that that study was way back in 1999. And we still have really poor adoption of lethal means counseling in emergency departments. And so it's unfortunate. And there are lethal means counseling training sites that are free. Boston or Harvard has one called Means Matter. And in summary, we're encouraging folks to identify suicide risk by using a validated screener like the ASQ. We encourage them to connect their patients. They have an easy way of doing that through mobile crisis. And then they should be providing at least some level of risk management or risk reduction, through lethal means counseling. In conclusion, wow, and I think I finished earlier. I guess I talked fast, really fast. Patients seeking mental and behavioral health care in emergency departments continues to rise. Many youth are suffering with suicidality, and universal screening is feasible even in busy PZDs. Pediatric ED, mental and behavioral health quality measures, improve processes, and safe planning innovations are beginning to develop, but require more attention and focus. The COVID pandemic seems to have had a negative impact on mental health, which may be increasing rates of youth at risk for suicide. Hopefully I didn't talk too fast, but that's usually like a 45-minute, hour-long talk. So I guess I was flying. I'll stop sharing so folks can see each other. Wow, the audience got big.
Yeah, so thank you, Dr. Rogers. It's such a difficult topic, and usually what we do is we kind of open it up right now to questions from the group. So I don't know if there's anything.
We'll be ending early as a holiday gift. I'm going to reframe that. It's a holiday gift for your mental health, so you can take a half hour to yourselves. But I'm happy to stay on as long as you guys need me to answer any questions. And then I'll pose one to you, Joe. Mm-hmm. How do we partner with you guys to provide better care for adolescents struggling with substance use disorder?
Yeah, so one of the questions that's kind of a good question that I have a question as well. So I know you've done a good job looking at suicide risk just by simply kind of asking the question with folks that come into the emergency room. What do you guys do to screen kids for substance abuse issues? And I guess that would kind of help us figure out how we might be able to help you best.
The easiest way to say it is not enough.
Yeah.
Really only our trauma kids get screened right now. And that's trauma kids who get admitted or test positive. They all get a drug screen. So if they test positive, they're screened for substance use disorder, but we don't currently have universal screening for substance use.
Is that
And
something that you guys think you may be headed towards in the future?
certainly something that's a possibility. Hasn't been on the radar. Again, I think we're not confronted with it often, even though it is we'll just say it's a much more common issue than we are presented with, if that makes sense. So,
Yep.
you know, we don't get a lot of kids and families seeking our assistance with their child's substance use. And I don't know why that is. I know other PZDs in other states do get a fair amount, and I don't know. You know, if anything, like I said, I applaud folks like you guys for somehow keeping them out of emergency departments. My recent sort of investigation to some of that also revealed to us that adult EDs, while responsive, don't do a lot. According to them, any medical detox. They hand them a prescription and say, you know, go home and get help. And so that was kind of the result of talking to a few EDs in our area.
Well, we're definitely, happy to partner with you to provide treatment for adolescents that do have mental health or substance abuse issues. I don't know if Ashley's on or anyone from the Middletown office, but we do have a behavioral health and addiction treatment arm specifically for young adults there, including outpatient medication management, PHP and IOP. So do we have anyone from Middletown on?
I don't believe Ashley's on right now, but this is Bill Savinelli. I'm the Director of Operations. Dr. Podolsky, you're correct. We do have a robust ADT, adolescent partial hospital type program, IOP program, mental health outpatient services in our Middletown location, but we can also see clients virtually. We'd be happy to set something up where myself, Ashley, Ray Bishop usually comes out to different sites in the Hartford area where we could come and visit with your staff and give them a brief overview of what we provide in our Middletown site, and throughout our system.
That'd be awesome. Yeah, I'd love to have our social work team, our psychiatrists and our social work team to learn more about your services so they can utilize them.
Okay, so perhaps we can set up an email and set up a date, a time and a date.
Yeah, Zoom makes that stuff pretty easy nowadays.
Yeah, so Bill and Dr. Rogers, I'll connect you both via email right after this.
Yeah, that's awesome.
Anything else from the group?
I may have missed this, Dr. Rogers, but at the beginning, the numbers that you were quoting, the 600,000 in that 5-year period, I think it was did that include telehealth or just kids that walked in with their parents?
I'm not sure I remember the 600,000 number.
Wasn't it 600,000? Now I'm forgetting what the exact slide was. It was a very large number of suicide risk patients, I believe, between 2018 and 2017, maybe in 21.
Yeah, so it was probably in the probably more like 6,000.
Okay, 6,000. Sorry,
at risk screens. Yeah,
slight difference. Did that was that including any telehealth visits to any of your providers or not?
No, we don't.
That's not doing that. Okay.
We have some spotty telehealth coverage, but again, we literally don't have we don't have an inpatient unit. We don't have any dedicated outpatient sort of psychiatric services. We do have a department of psychology, and I think we have about 20 psychologists. We're in the process of building our own psychiatry division, and we have, I don't know how many social workers engaged with patient care. I mean, they have some subspecialty clinic specific social workers who do provide therapy and likely do provide some telehealth, but we certainly don't have like a telehealth system, and we have one clinic that's called our transitions clinic that was really designed to help decompress the ED. So if patients need like an appointment the next day, and we're kind of reinventing that clinic now, wasn't a very financially viable model. It's difficult, and I know, again, I'm preaching the choir with you guys. It's difficult to make money and fund programs in mental health, and so our institution wants to expand. They just need to do. We need to do it in financially viable ways that will be sustainable. And so we're flexing when we need to, but it's been tough.
Thank you.
Sure.
Yeah, so thank you, Dr. Rogers. Unless there's anything else, I will connect right after this call, Bill, Dr. Rogers and I, and
Great.
thank you very much, everyone.